Hi guys, this is Madison Cronin Burrows,
This is Elijah Abdullah.
This is Carrot Carter.
And Zach Carson.
and today we're going to talk about the bone healing process and how as a clinician we can treat them. So there are three stages in the bone healing process. There's the acute stage, the repair regeneration stage, and the remodeling stage. And we're going to talk about all three of those stages next. During the inflammatory stage, a hematoma is formed. Inflammation occurs. Angiogenesis, which is the formation of new blood vessels, also occurs, and the initial development of a fibrous soft callus begins. This stage can last up to a week. The hematoma acts as a source of cells and platelets, which initiates inflammation. Platelets prevent further blood loss, which helps the fracture site from becoming hypoxic and acidic. During the inflammatory response, mesenchymal stem cells promote callus development. Woven bone is then deposited beneath the periosteum at initial callus development and is several millimeters away from the fracture ends. At the fracture site, a second callus formation occurs. This is referred to as a soft callus, which is the first step in regenerating bone. Avascular fibrinous scar tissue is also generated.
So next you have the second stage of bone repair. So this stage is repair and regeneration. The way I like to think of this stage is like patching a hole in the wall. And it could be considered one of the most important stages of bone healing because if it's not done correctly and gradually enough the first time, then you're going to have to do it again, or there's a better chance that it could break a second time around. So this stage can last 8 to 12 weeks. From the hematoma, a thick mass of callus forms around the ends of the fracture. This soft callus eventually hardens over a course of several weeks. So during this stage, the pain and swelling begin to subside and become fibrous and cartilaginous tissue. This is also the stage that woven bone begins to form, making the bone more stable and increasing the structural strength of the bone. The soft callus is comparable to plastic as it can easily bend and deform. This is why whenever somebody gets injured, initially you want to splint it and then you want to keep that bone supported during this stage as you want it to grow back the way it should and not bent or offset. Then the hard callus is weaker than the original bone, but it can still withstand the stresses of daily life that the original bone went through before. The third stage of bone healing is the remodeling stage. So this stage can start as early as the 21st day post-fracture and can continue for several years. Woven bone is replaced by cortical or trabecular bone as it is remodeled and replaced. So this is similar to the original bone. Osteoclast and osteoblast remodel the bone. This is determined on the mechanical loading. Treatment during this stage is gradual increase on the mechanical load.
So is the tissue regenerated or repaired? Bone is one of, if not the only tissue that repairs itself it's regenerated rather than just repaired. Popular idea is that bone is repaired stronger when it heals from being fractured. This is because bone is regenerated, not just repaired, unlike ligaments. With a ligament, if it is injured, it is permanently more lax for the rest of the athlete or patient's life, and will never return to the same strength as it had before. So if a soccer player sprains their ATF, they're more likely to sprain it again just because there's not that tightness as there was before. But with bone, because of the stresses that bone has to put up with daily by just going through activities of daily living, it's able to regenerate itself and become just close to as strong, if not just as strong, as it was before it was fractured. And a lot of times even there can be an excess growth of bone at the fracture site compared to the contralateral site.
Hey guys, it's Elijah here, and I'm going to talk about fracture management. Now, first things first, if a fracture is detected, your immediate response should be to splint them and refer them and get them in to get an x-ray as soon as possible so we can see what exactly we're dealing with and what type of fracture it is. Now, during the acute stage, what you want to do is avoid re-injury and aggravating inflammation because we want to get through that stage as quick as possible. And during the regeneration stage, you want to avoid disrupting the healing tissue and avoid quick changes in mechanical loads. Now, during the remodeling stage, you want to avoid quick changes in mechanical loads. All right, now these are our treatment goals. First and foremost, immobilization and protection is first thing is what you want to do. And then you want to manage discomfort, minimize swelling and hemorrhaging, promote optimal healing conditions, promote optimized tissue formation, minimize stiffness, gradual restoration of range of motion, minimize atrophy, gradual strengthening, and restore muscle strength, power, and endurance.
So just because of the type of injury that a fracture is, it's difficult to determine what kind of treatment, not what kind of treatment you're supposed to give, but when you're supposed to start the treatment. Just because you can't see a bone, so you can't really see when the fracture is healed. You can't see the state of the bone day to day. And one of the biggest indicators to when you're able to start treatment is based on what kind of fracture it is and how long those typically take to heal. So like with a stress fracture, I've seen patients just thrown in a boot for a couple weeks, maybe even a month or two, just to take all that pressure off of that site. So if they had fractured their foot, they have a stress fracture in their foot, put them in a boot, takes all the pressure off of the foot, so that they're still able to use their foot and still able to do the things that they do daily, but the bone is able to heal. With a green stick fracture, it's a little bit more serious. They're probably going to be put in a cast for this. Generally, green stick fractures are correlated with union fractures because green sticks it's still a fracture, obviously, but the bone isn't going anywhere. The bone is still together to an extent. And then compound fractures are typically put together with non-union fractures because when an athlete goes through a compound fracture, it's essentially like breaking a stick, and then that's how the bone is just put together, is how the bone ends up being after it's broken. Another issue that can come with compound fractures is that it can poke through the skin, which if that happens, then you have to deal with that as well. But compound fractures will definitely need to be put in a cast, a hard cast, and how long they're in that cast depends on how bad the fracture is. And a spiral fracture is probably the worst kind of fracture that an athlete can undergo. It's going to take the longest amount of time. It's going to be compound as well, and it's also going to be non-union. And it's just going to take forever to heal. Length of immobilization, how long you immobilize the limb, is going to determine how you want to begin your treatment, how much range of motion you want to start off with, how much just body weight stuff you want to do so that the bone is used to dealing with the stress of just the patient's body weight, and then progress them from there. Obviously, you don't want to progress them further than they're comfortable with. So if they have pain with something, back them down off of it, and just do to where it's still pushing them, but the patient isn't in agonizing pain. And then just to be safe, if you have the funds and the facilities available, x-rays are always going to be the best indicator for when to start treatment plans. And then these are our resources.
Thanks, guys, and thanks for watching Disney Channel.